So hello everyone and a very warm welcome on behalf of EuroELSO. This is our latest edition of our brand new webinar series. And my name is Peter Schellongowski. I will be your moderator today from Vienna, Austria. And it's a very special pleasure to welcome today our expert from Berlin. This is Felix Hennig. Felix, who after training in general surgery and in traumatology, received his degree as a board-certified cardiac surgeon, and he specialized in all sorts of thoracic things, and most overall in mechanical devices in heart failure, which will be the topic today of our webinar. And the title is Transition from Veno-Arterial ECMO to ventricular assist devices. So Felix, thank you very much for making yourself available and for putting all the effort into the presentation that you will give to us. We are very excited about it and looking forward also to the discussion which we will have after your presentation. Now, to our participants, thank you for taking your time today and for joining EuroELSO webinars. In the panel of the webinar tool, you will be able anytime from now on to put down your questions, and I will hand them on to Felix in the moderated discussion part. So please participate. This is your unique chance to ask questions to an expert and to ask everything about the Berlin experience on this topic. So once again, Felix, thank you very much for being with us today, and this is your part now. We are waiting for your presentation.
Thank you. It's my pleasure. It's a great opportunity. I'm very glad. I hope you can see that. Should be, yeah. There it is. So obviously, again, thank you for the invitation. And first things first, I have nothing to disclose. However, during that talk, you will realize that I still use that old acronym ECMO, where perhaps ECLS would be more appropriate and should be used instead. Another aspect to disclose is that most of what you will hear today is probably not really evidence-based at a very deep level. However, it's perhaps more a collection of personal experience, or if one would call it personal mistakes that I made at one point or another and that I didn't want to make again, so I wrote them down. It's obviously about transitioning patients from VA ECMO to durable VADs. However, the first slide that I produced is one about weaning from ECMO, and the most important thing that I want to tell you is do not wean patients to heart failure. I'm not really sure whether or not, yeah, now you can see it. Do not wean patients to heart failure. I took this graph, and once your patient needs an ECMO for chronic heart failure, you're probably somewhere down here. And at this point in time, it's really questionable whether or not you can wean your patients back to a normal myocardial function. That means immediately we start to screen patients for large ventricles with thin walls, because these patients normally present as an exacerbation of chronic heart failure, and they are probably not ideal candidates for weaning. Additionally, during your echocardiographic evaluation, stroke volume is sometimes much more precise than ejection fraction alone, due to changes of geometry of the ventricle and function of the ventricular wall. You may well see patients with an ejection fraction of 30% that produce stroke volumes of about 30 milliliters. And if you take these 30 milliliters times 100 heartbeats per minute, that's 3 liters per minute of cardiac output. That's certainly not enough. And these patients are perhaps better off if you let them have that transition to VAD instead. So the next thing is I call that the plan that's what we plan for every patient. And then I realized that that if I think about it, it's actually, as they say, no battle plan survives contact with the enemy. That means we try to stick to these principles. However, in some situations they are adapted to what is actually needed. So they are more a general guiding line than something that we follow dogmatically. Obviously, before we implant durable VADs like the hardware or the heart-made pump, we want to see satisfying cerebral function in these patients. If someone from the outside asks us what's satisfying cerebral function, we tell them that we want to discuss the VAD's owner manual with the patient. And there is some truth to that. However, in most conditions, it's enough if the patient is able to give his consent to the operation. And in some situations, it may be sufficient to see and to prove that the patient has no focal or neurological deficit. That means you try to wake them up, they move all four extremities, and you have no evidence of cerebral failure, then that's probably enough. We want to see improved and stable end organ function. That means we don't want to implant durable ventricular assist devices in patients who are still in massive worsening liver failure or who have a massive pneumonia. We want to see that sorted out and stabilized before we proceed with the operation. We want to see improved or stable right heart function, if that is possible. It's a problem with patients with terminal heart failure that the right ventricle deteriorates as well. And for a left ventricular assist device, you need a working right ventricle. Otherwise, it's not going to work. And we want to see stable right ventricular function. If we don't see stable right ventricular function, at least we want to know about it, and we want to be prepared, and we want to know that we did everything to help the right ventricle to recover. And if that's not possible, then we have different strategies to deal with that. And last but not least, we want to complete diagnostics in these patients. What we actually do is something like something that we call a concise transplant workup. That means we obviously in a patient on ECMO we wouldn't perform a colonoscopy or something like that, but we want to make sure that they don't suffer from any disease that would preclude successful long-term outcome. And we had that happen, that we had patients on ECMO who recovered, and during that time we found out that they actually had small cell carcinoma. That's really bad, but that's something you want to know before. In the end, what we want to achieve is we want to have that implantation as close to an elective procedure as possible. So there is almost no reason once you have the patient on ECMO to rush it and to perform the implantation as an emergency procedure. There is perhaps one or two exemptions to that rule. If we have already made the decision to implant a VAD and prior to the scheduled point in time the patient experiences left ventricular distension and pulmonary venous hypertension, then perhaps we would proceed with the VAD implantation urgently. Or if we see ischemia in a peripheral vessel in arms and legs, then again, if the decision for VAD implantation is already made, then we would proceed with that at an earlier point in time. But that's about the only exception to that rule. It should be as close to an elective procedure as possible. The next thing that I want to talk about is something that we call a three-step evaluation of our ECMO patients. What that means is once we have the patient on ECMO, there's different stages of diagnostics that we perform with them. First is And that's especially true for patients you got through ECPR, through ECMO-assisted cardiopulmonary resuscitation. After I have implanted an ECMO circuit for these patients, I don't leave the other hospital without having a chest X-ray, because I want to rule out pneumothorax or hematothorax as a consequence of chest compression. And I don't leave the other hospital without an abdominal sonography, because I want to rule out that the patients have lacerations of liver and spleen. And I actually lost patients because I didn't do that. I had them on ECMO and everything was fine, and then during the transport I realized that they were bleeding massively into their abdomen, and that's completely unnecessary. And so before you hit the road with someone after ECPR, perform a chest X-ray and abdominal sonography. Doesn't cost much and may save a life. Second is diagnostics for myocardial recovery. The talk is about transition to VADs. However, our aim primarily is to have these patients recover their myocardial function. And for that, there is several things we do. We perform echocardiographies. We have very dedicated echocardiographers. And if we ask them, they do that every day. And it's hard on them, but it really helps. We want to rule out any problem that can be corrected surgically. We perform coronary angiography because perhaps there is something that could be revascularized that may be true for the left ventricle. It also may be true for the right ventricle. Even in a VAD patient or in a prospective VAD patient, it may be useful to revascularize the right circulation to improve right ventricular function. That's subject to debate, and there's different opinions about that, but it's good to know. And we perform biopsies, or our friends from cardiology perform biopsies to rule out myocarditis, amyloidosis, whatsoever, something that you could treat medically. And last but not least, there is diagnostics for successful long-term support. As I already mentioned, at least we want to perform something, we want to perform a computed axial tomography, a CAT scan, to rule out any kind of malignant disease, and we perform neurological workups as needed and as dictated by the clinical situation. And then what I did is I wrote down something that I called trivialities for several organ systems. Most of these patients die from problems related to the brain, from problems related to the lungs, and from problems related to the liver. And this is what we try to focus on. That means, especially in ECPR patients, I know that's not evidence-based, but as far as I'm concerned, I still put eyes on head and neck of these patients. I try to administer propofol as early as possible to slow down metabolism of the brain. Obviously, like everyone else, we try to maintain cerebral perfusion pressure, and we use NIRS, near-infrared spectroscopy monitoring to make sure that the patients actually have adequate cerebral perfusion. We keep the head of the bed elevated more than 30 degrees. That's also a triviality, but more often than not, you find that this is left out, and it reduces drainage of the brain. There is different regimes of transfusion worldwide. I think we are among the more traditional schools, and we try to maintain adequate hemoglobin levels. What adequate means is obviously again subject to discussion. I think perhaps we would try to keep hemoglobin up to 10 grams per deciliter. We try to prevent volume overload because that will again damage the brain. However, we try to maintain mean arterial pressure for cerebral perfusion. Obviously, glycemic control is important. And one point about targeted temperature management, there is new data regarding that topic. In patients in whom you anticipate transition to VAD, the problem is that it takes at least a few days for if you decide to perform therapeutic hypothermia targeted temperature management. It will delay the VAD implantation for at least 3 to 4 days. You need to keep the patient cooled, you need them sedated, you need to warm them up, then you need to reduce sedation. And these patients need some time to wake up. So if you perform targeted temperature management, keep in mind that it will slow you down a considerable amount. However, we try, or obviously we avoid fever at all times. That's for sure. And last but not least, if you see patients who early after the VAD implantation already show signs of hypertension and polyuria, and especially combined with bradycardia, that may well be a first sign of, or first manifestation of Cushing's reflex, and may indicate elevated intercerebral pressure and perhaps brain death. And it happens, especially in ECPR patients, that at this point in time, obviously you would not transition to VAD implantation, but sometimes the only thing that you can do is talk to the family about organ donation, and that's about it. Then I have the same kind of trivialities for the lung. Again, we try to maintain negative fluid balance as you would do it, for example, in your ARDS patients. Now that's easier said than done, and it takes an enormous amount of effort, especially by the nursing staff, to save every milliliter of fluid on these patients. But it's actually really worthwhile, because you have better lung function, you have better chest wall compliance in the end, you have less edema of the intestines, and all of this makes recovery of these patients, especially after VAD implantation, so much more easy. We try to maintain positive airway pressure. That's especially important in patients in awake ECMO, especially important in patients who are extubated on ECMO. We keep them on non-invasive ventilation. We try to maintain continuous positive airway pressure, because these patients tend to develop pulmonary edema rapidly, and it's good to prevent that. Again, we try to keep the head of the bed elevated 30 degrees in some sort of reverse Trendelenburg position. Obviously, as everyone knows, that prevents aspiration, okay, but it also reduces pulmonary venous pressure and pulmonary arterial pressure as well. So it reduces your chance of pulmonary edema. And as you have the patient in reverse Trendelenburg, if you are really lucky, you pool blood to the lower part of the body, and this is actually where part of your venous multistage cannula is, so you can achieve that without reducing ECMO flow. Like everyone else, I think we try to condition the diaphragm by daily drug holidays and spontaneous breathing trials. Again, these patients are susceptible to pulmonary edema, and if we are suspicious of pulmonary venous congestion as indicated by echocardiography or falling lung compliance, we would vent the left ventricle by means of an impeller device, or if it's only the pulmonary venous, the pulmonary circulation, we would perhaps perform a septostomy. However, our first approach is always the impeller system, and septostomy is reserved for special situations, if you like. The liver, a quick implementation of ECMO support. That means it's extremely important to limit the amount of time that these patients are actually in cardiogenic shock. And that's a mistake that we ourselves make in our department, and it has happened to me before. If you see these patients for a prolonged amount of time, the longer you see them, the harder it is to sometimes make a decision. And if they are really crashing and burning, obviously you proceed with ECMO. If they are healthy, you don't need an ECMO at all. But those that are in between, and I learned that some years ago that sometimes, especially with VAD patients, it's better 5 days too early than 5 minutes too late, and that holds true with ECMO as well. We try to avoid hepatotoxic drugs whenever possible. There is drugs that are well tolerated by the healthy liver, that are not so well tolerated by patients after cardiogenic shock. Meropenem, for example, is one of those substances. Obviously, there is clear indications for them, but we try to avoid them if possible. We try to prevent hemolysis. This is achieved by choosing proper cannula for the amount of flow that you want to provide to the patient. Watch out for clotting of the membrane lung. It happens rarely, but that may produce massive hemolysis. And obviously, transfusion is also important. There is colleagues, I don't name them, but some of us go to the blood bank and we select the freshest packed red blood cells that are available. We try to prevent venous congestion, especially in patients with massive right heart failure, because continuous elevation of central venous pressure over 15, over 20 will almost shut down liver function, so that's extremely dangerous. And obviously we proceed with enteral nutrition as soon as possible, in whatever degree. At least we try to avoid total parenteral nutrition. And as I said earlier, if liver function is not stabilizing, if bilirubin is above 10 milligrams per deciliter, we would be rather hesitant to implant a VAD. We did that, and sometimes it worked, sometimes it didn't. But actually we want to see stable and improving liver function. And last but not least, if patients, especially after ECPR, present during the first day with high lactate, hypoglycemia and hypothermia, this may very well indicate severe liver damage, and in these patients it's worthwhile to consult a specialist from gastroenterology, or for example from the liver transplant team early to help us figure out if there is something that can be done for the liver. As I already said, weaning from ECMO is preferred. That was my first slide, and that's true. However, as I said, we don't want to wean patients in exacerbation of severe chronic heart failure. And we don't want to wean them if ejection fraction is still low and if stroke volume is still low. And obviously we don't start weaning without improvement of end organ function. However, we try to time the whole clinical course in a way that enables us to have the ECMO circuit explanted within the second week. That's more or less arbitrary. It's something that we have decided on in our department because we feel that the first week is rather uncomplicated, and during the second week, that's when we start to see problems begin. And this is why we try to have the ECMO circuit out in these patients within the second week. If that is by mistake, and if the patient recovers his myocardial function after we have implanted a VAD, it's still possible at all times to explant the VAD and there's no damage done. But in patients who are no candidates for weaning, within the second week, we try to have the VAD running. Something about surgical technique. We try to implant the assist device on ECMO. That means we have the patient on ECMO, we use the ECMO cannula, and that's probably something that saves a lot, because these patients suffer from coagulopathy after the ECMO run, and so we try to change as little as possible. We use a heart and lung machine, but we use it only if it's required by surgical strategy. That means if during our evaluation we found out that the patient has a persistent foramen ovale, that may become a problem during the or immediately after the VAD implantation. Obviously that needs closing, and for that you need to open up the right atrium, and you need to cannulate the superior and the inferior caval vein, and that's best done by means of a heart and lung machine. Same for patients who have aortic insufficiency. In VAD patients, it's worthwhile to consider replacing the aortic valve during the initial implantation, because we know that the exposure to continuous flow will over time make aortic valve insufficiency worse. So in these patients, obviously you need cardioplegia, and for these patients we would use a heart and lung machine. Same for tricuspid valve repair, or if we see intracavitary thrombus that needs removal, because otherwise it would end up inside the VAD and would destroy it. Even if we use a heart and lung machine, we still try to use the ECMO cannula. That means we simply cut the tubing to the ECMO cannula and connect it to the heart and lung machine, because we want to avoid bleeding points in the chest, in the thoracic cavity. Obviously, if you have to cannulate the superior caval vein, then in most cases you need to add one cannula that goes into the chest, but that's about the expectation from the rule. In redo cases, like most centers, we would perform a lateral thoracotomy and suture the outflow graft to the descending aorta. That's also pretty standard nowadays. We still use open chest treatment if necessary. Necessary means in diffuse bleeding, and we would leave towels in the chest to stem the bleeding, and we would come back after 2 days and take them out, close the chest. Or for right heart failure that is severe enough to preclude chest closure, but not severe enough to need a right ventricular assist device, open chest treatment is something that still carries the risk of infection, and especially with a large foreign body like the VAD, it's something that should not be undertaken lightly, but it works, and we still do it. Once the implantation is done with and the VAD is working, we explant the peripheral cannula according to principles of vascular surgery. That means we perform thrombectomy, we reconstruct the vessel. If it's not possible to reconstruct it because it's heavily damaged, we would replace it. We try to avoid pericardium nonsense. We try to avoid Gore-Tex, and we try to avoid Teflon felts in these femoral vessels, because they are most often contaminated already, and we try to use pericardium, bovine pericardium, because that's a little bit more resistant to infection, obviously. And especially in these patients, and especially as long as they are under the influence of analgosedation, it's worthwhile to be aware of the possibility of compartment syndrome, because that may well develop even after the ECMO cannula is out, and it's very sad if you realize it too late. I have this rather simple picture that I harass people with. I hope you can see it. It's a drawing that I made. This is basically why we perform, why we do not simply pull the cannula out. Because if you have your arterial ECMO cannula inside the femoral artery and you have your leg perfusion cannula, I like 8 French super Aeroflex sheaths, because as you see, they are a little bit longer, they are wire reinforced, and I use them basically at all times. For me, they work very well. But in between, you find clot always. The amazing thing is that even if you do not remove that, it doesn't always lead to clinical problems. So that's the good side. However, sometimes it does, and it's unnecessary. You can simply open up the groin, and while you take out the ECMO cannula, you simply remove that thrombus by means of a simple forgetting maneuver, and you don't see that problem. The last thing I want to mention is that we use less and less biventricular assist devices and less total artificial hearts. You can see that green is the normal left ventricular assist device, blue is the BiVAD and total artificial heart, and in 2018 it was all left ventricular assist devices. However, there is a significant number of patients, and that's about 10, 15, 20%, depends, who, although they get along with the left ventricular assist device only on the long term, during the acute perioperative phase, they need a temporary right ventricular assist device. And patients who are bridged to VAD implantation on ECMO and who receive the ECMO for eCPR or for refractory cardiogenic shock are more likely to end up with a temporary right ventricular assist device. And so the last point is obviously be prepared for right ventricular failure. There is different ways, different options to deal with that. Perhaps one of the easiest ways to deal with it is to take a 10 millimeter Dacron graft, woven Dacron graft, no Gore-Tex, because they tend to bleed, and suture that onto the pulmonary artery, and then close the chest and let the graft come out in the below the xiphoid, and then connect it to a CentriMark pump. And so you have a really reliable way to support your patient. It's extremely useful, or it's especially useful in patients, even if that's rare, but in patients who need permanent support. Because if you need to implant a second hardware pump, for example, as a way to support the permanently failing right ventricle, then your 10 millimeter Dacron graft will connect straight to the outflow graft of the hardware pump, so you don't need to do anything with the pulmonary artery. You simply have to deal with the inflow cannula, and the outflow cannula is already in place. The second option that's also getting more and more popular, and I think for good reasons, is the long percutaneous cannula to the pulmonary artery. That has obviously been published elsewhere. What we do is we put a balloon tip catheter into the right internal jugular vein, and under fluoroscopy we float it to the pulmonary artery, and then we use a long cannula that we guide into the pulmonary artery after we have exchanged the balloon tip catheter for a stiff wire, like an Amplatz super stiff wire, something in that direction, and that works actually really well. There is one problem with that. if the patient is rather tall, most standard ECMO cannula are probably too short. The longest that we have available is the long venous biomedicus cannula, and in smaller patients or normally sized adults that works. However, if your patient is very tall, then the cannula will move out of the pulmonary artery and dislocate into the right ventricle, and obviously then it's not working any longer. And at this point, it's also extremely difficult to put it back into the pulmonary artery, because you need wires, you need fluoroscopy, and if the patient needs right ventricular support, then all of this needs to be done under massive hemodynamic instability. So in taller patients, it's probably not the best idea. There is one company, I forgot the name, that is now producing cannula that is specifically designed for that, and that comes with an appropriate length. In these patients, we try to drain using the femoral vein if possible, simply because it's already in place, and we want to avoid points of bleeding at the right atrium, especially if the patient is in chronic right heart failure. The right atrium, and especially the wall of the right atrium, may be rather friable, and sometimes it bleeds profusely, and sometimes it's not easy to deal with that, and you can completely avoid it by simply cannulating the femoral vein. And especially if that cannula is already in place, then you don't need anything else. Now, additionally, there is systems that are available as percutaneous right ventricular support devices. There is one from Impeller. There is another one from Tandem Heart, but we have used the Impeller RVAD, but I think most of our patients, if they need right ventricular support, we still sew a graft to the pulmonary artery, or we use a long percutaneous cannula to the pulmonary artery. And obviously, if these patients at one point or another require support of gas exchange, then it's very easy, very convenient to simply integrate a membrane lung into the right ventricular assist device, and you don't need a VV ECMO in these cases, obviously. And that's what I wanted to say. Actually, I hope to see at least some of you in London, and that's it. Thank you.
Felix, thank you very much for your very concise presentation on how you approach the topic of transitioning patients from ECMO, from VA ECMO to ventricular assist devices. Thank you very much. Now, I once again invite our participants to put in the questions. We have a couple of questions already by now, but you can enter some more until the very end of this discussion. So Felix, the first thing I would like to start with is you spent quite some time of your presentation on the timing to transition. You said that usually in your center you try to get rid of the ECMO in the second week of the support, either in terms of weaning or in transitioning to ventricular device. And you also mentioned a couple of criteria that you use to decide if a patient is not weanable. You mentioned an ejection fraction of less than 30%, whereas you also said that stroke volume is very important. You said that you need to ensure proper end organ perfusion as a very important basis to decide how to proceed. And that usually patients who go to ECMO with a severe exacerbation in a already chronic condition are mostly not patients that will make it to a weaning process. Now, you said that you have a great echo team and that they will come, if you're very nice, every day and support your decision taking. Do they use any specific echo criteria in deciding who's ready to wean or who will fail weaning? Is that something, do you have an algorithm for that, or is it a case-by-case decision?
So obviously I'm not an echocardiographer myself. I mean, I know how to switch the thing on, and that's about it. It's actually a decision that is made from patient to patient, and everything that I said obviously depends on the clinical situation. Especially to start with that, what I said with trying to get the ECMO out within the second week. Obviously, if we have a patient who has myocarditis, and that's something completely different. If it's an acute problem, that's something completely different from someone who is known to have dilated cardiomyopathy, who has a left ventricular end diastolic diameter of 80 millimeters and very thin myocardial walls, because it may very well be possible to wean even these patients. It's if you really want to do it, then it's probably possible. The question is, what are you weaning them to? Obviously, that the patient with a myocarditis, he has a realistic chance of recovery, and perhaps in 5 or 10 years he will come back with dilated cardiomyopathy. That's something completely different, but there is a real chance for myocardial recovery. And in these patients, obviously, we would not be so dogmatic on having the ECMO out within the second week. But in a patient who presents in an exacerbation of chronic failure, if you don't have anything that you can reasonably do to make the heart better, then the only thing you can wean them to is the functional status that they had before they went into refractory shock, and the heart is as bad as before. So most probably they will present with the same problem within weeks or months if they are lucky, and then they need another second ECMO run, and perhaps they are not as lucky as during the first run, and that has happened to me. Sometimes we made that decision and sometimes it was wrong, and then the patient came back after 3 weeks under CPR, and actually that was completely unnecessary, because we saw it that the heart was done with in the first place. So actually we have no, I hope our echocardiographers and our cardiologists see it the same way, but I feel that we have no clear-cut criteria. So there is no single number that I know of that you can measure to make that decision.
But so it's a case-by-case thing, and it's a joint decision taking of several specialized teams.
Everyone is talking about heart teams nowadays, and you have them for the weirdest reasons. But in these patients, and if you visit us, you'll see it's actually the case. We stand at the bedside, and there is 1 or 2 cardiologists, there is a pulmonologist, there is an intensive care specialist, sometimes there's an anesthesiologist, there is a cardiac surgeon, there's one from the transplant team, one from the MCS department. So we really try to sit down, and we try to figure out. That's not always an easy decision, but that's something where you really need your heart team. For everything else, I don't know, but that's something these patients really benefit from that, I would say.
So since the indication for ventricular assist devices is such a critical point here in this process, I have 2 more questions. The one would be, do you have a standardized protocol for weaning in terms of how low do you go with the ECMO flow when you test weanability, so to say? This would be the first one.
So we start with, like everyone else, we start with ECMO flows that we cannulate as we do for the heart and lung machine, perhaps a little bit less, 2 liters per square meter body surface area. That's about it, and it depends on the pathophysiology. Sometimes in sepsis you need much more, and sometimes you need less. It depends on whether or not the patient is pumping blood on his own, but that's what we start with. And then we wait until the metabolic derangement is gone. So actually we want to see lactate down, want to see that the patient has his normal aerobic metabolism, and we want to see that the patient needs less and less inotropic support. There is different philosophies behind that, but personally I try to wean patients off vasopressors more aggressively than inotropes. So noradrenaline, I try to get rid of this as soon as I can without compromising perfusion pressure. And I try to keep inotropic support, like that would be adrenaline in our department. Other hospitals may use Dobutamine. I don't know. Sometimes we still use adrenaline, and then I wait until the patient starts to eject more and more blood, and I see that once I see they develop hypertension, we try to start them on nitroglycerin, and if that's not enough, then that's the ideal point in time, especially if it's a patient who is not really a candidate for a VAD because perhaps he presented an acute failure and it's realistic to wean them, or perhaps it's a patient who for secondary diseases, perhaps malignant disease, is no candidate for VAD, and that's a good point in time to start them on heart failure medication. Again, that's something that we discuss all together and in small doses. And once we have that, then we think about reducing ECMO flow, and that's something that we do, perhaps 500 cc's, perhaps 1 liter per day. That depends on the amount of flow that we have started with. Obviously, it's much easier to wean someone from 7 liters to 6 liters. That's very easily done. If you start with 3.5 liters, then perhaps you want to go a little bit slower. We are rather sure that the ECMO circuit is perhaps safe from clotting, or not too prone to clotting until we reach a flow of 2 liters per minute, perhaps. I know that there's other departments who go even lower, but we start to become uncomfortable once the flow is below 2 liters. And again, that's all. While we do that, we have echocardiography in place, and we want to make really sure that works. Once the patient goes up with lactate or needs vasopressors again, then we stop that and we take the flow up again, because we want them to have stable conditions. And
now you are using heparin for anticoagulation, I assume.
Yeah.
And is that a PTT guided heparinization, or you go for ACT?
We have different options for that. Now, if we, for example, during a lung transplantation, we use ACT. We have three transplant surgeons. We do our lung transplantations on ECMO, no heart and lung machine. For that, we use ACT in the operating room. Small amounts of heparin, so low ranges of ACT. You need special cartridges for that. ACT of about 160 to 180 should be enough for lung transplantation. But for these VA ECMOs at the intensive care unit, we use APTT, and we target APTT to about 60 to 70. However, that's dependent on, as you know, there is so much to integrate into that. Obviously, it's something completely different if you have a patient who has had cerebral bleeding, in whom you would perhaps go much lower and risk changing the ECMO circuit, as to compared on the other side, someone who has a mechanical composite graft placed into his aortic root, and if you don't give them enough heparin, that will completely clot off and you will clot the coronaries, and then you have really done something. We use heparin in most patients, as you already said. In patients who are HIT positive, we use agatroban. There's obviously other centers who use Refludan, Devaluron, or whatever. We use agatroban, and it works rather well.
Okay. Now, when you you mentioned that you perform venting procedures when you think it's indicated due to pulmonary venous congestion. Can you think of a situation when you consider venting, that you decide instead of venting the patient, you would go to VAD implantation very early at this stage?
Yeah. Now there is obviously different reasons to think about decompression of the left ventricle. If you are a cynic and if you work for a VAD program, then you can obviously say, I don't care about the left ventricle, it's gone and the patient gets his VAD, and so let's get over with it. But the problem is that once filling pressures in the left ventricle rise, filling pressures in the pulmonary, filling pressures in the left atrium rise, and pulmonary venous pressure rises, and you end up with a destroyed lung. So that's something that we are afraid of, because once you have managed to destroy the lung, actually everything else is futile. The VAD itself obviously is an extremely powerful tool to unload the left ventricle, and I mentioned that very shortly. If we have already made the decision that the patient is a suitable VAD candidate, then we would perhaps go straight forward with the VAD implantation. If it's in a rather early stage and there is still the diagnostic workup is not yet completed, then in most cases nowadays, I would say in almost all cases nowadays, what we would do is take a 10 millimeter dark-run graft, suture to the right axillary artery, and then use that to implant a large impeller pump, the 5.0 impeller pump, and use that as a vent. That has several advantages. It's expensive, and that's an important point. But the advantages are you really unload the left ventricle, you unload the pulmonary venous circulation, and once the patient is becoming more and more stable, you can wean the patient off ECMO, and now you have them supported only by the impeller device. And at this point in time, as that is, if you may say so, a real LVAD, you already know that your patient has decent right heart function, because otherwise he would not tolerate being supported by the impeller circuit alone. And so this is why we are at this point in time rather partial to use the impeller device in these patients.
Okay. So Felix, you mentioned that you try to keep the cannula that you have for the VA ECMO when you, at least the venous part, when you go to heart-lung machine. And one of the questions of one of our participants is if that's really sufficient to keep up the flows that you need in the heart-lung machine. And I would assume that this is a matter of the cannula size. Do you agree with that? And what kind of venous cannulation sizes do you use in these patients?
So obviously, there is certain rules that you need to follow if you want to have your heart and lung machine work successfully, and that's that. I think, dependent on the patient's size and anatomy, you will probably be able to support most of the patients using femoral cannulation alone. So for me, it's difficult to say, but in a standard situation, a normally sized adult male, I would depend on the situation. I would go with I would implant a 17 to 19 French short HLS cannula for the arterial return, and I would use normally a 23 French, perhaps a 25 French long HLS cannula for venous drainage, and that should actually give you capabilities for up to, I would say, 6 liters without problems. And if you are in doubt about that, then talk to your colleagues in cardiac surgery who do mini mitrals. Every every mini mitral that you do is done using femoral cannulation, and that's with cardioplegia as well. And you can, in most cases, you can support your patient sufficiently using femoral cannulation, and so we are actually, in most cases, we are rather happy with that, and it works nicely, I'd say. There is, however, obviously it's true, there is situations where the anatomy is not dictates another approach, and sometimes it's not, perhaps it's not possible for reasons of anatomy to place the cannula accordingly, or obviously, and then you need to do something else, and you need to cannulate the right atrium or the cable veins and the ascending aorta. But normally, I would say that's not necessary, and everyone who does mitral valve repairs will tell you that that's actually what they do every day.
Okay, so you mentioned the topic of temporary right ventricular assist device in those patients, and this is something that in my center is also performed in a percutaneous way, and I'm totally fascinated about this concept, because we can back then at times patients had to have an open chest to have the cannula in place, and nowadays they may be extubated, immobilized, and the removal is just a minor thing, with maybe a minor thing with a local anesthesia, and just sticking the end of the graft below the skin. So this is, I think this is a major advantage. So there's two questions to the temporary RVAD management. How do you decide intraoperatively that a patient will probably profit from this? And the other question will be, what's the average number of days that you will keep this in place in a patient post that procedure?
So once the left ventricular assist device is implanted, and the patient is still on ECMO or on bypass, more often on ECMO than on full bypass, we would then start the VAD and start inotropic support with adrenaline to support the right ventricle. We would then adjust filling pressures on the right side to CVP, to central venous pressure that doesn't distend the right ventricle. We use, like everyone else, we use nitric oxide to reduce right ventricular afterload. So we try to optimize the conditions for the transition from ECMO to VAD. And then gradually we wean down the ECMO circuit, and we come up with a VAD flow. During that procedure, the anesthetist, our anesthetists are also, actually all of them are brilliant echocardiographers, so they have their TE probe in place during the whole procedure. And they watch the size of the right ventricle, and they watch the size of the left ventricle, and what helps me is I'm always interested in the position of the septum of the atria, because what you want to avoid is to suck the left ventricle empty by using your VAD. So once you empty out your left ventricle because you have run your VAD on too much revolutions per minute, you will distort the right ventricle, and then you will surely induce right ventricular failure. And then you will see a large right ventricle, a small left ventricle, and you will see the septum of the atria go to the left side, because the filling pressures on the right side go up. And at this point in time, if that happens, we try to avoid that. We would go down with the VAD flow and go up with the ECMO flow. So that's the basic principle how that works. We don't want to use excessive amounts of catecholamines and inotropic support in these patients. And we, if they transition without any problems, obviously that's easy to realize. If you can run the full calculated blood flow on your VAD, that's easy. If it doesn't work at all, that's also easy to realize, because you cannot pump anything, and these patients then need a right ventricular assist device. The problem is those in between, and if we are not able to figure that out, then we simply wait 1 hour and see how the patient does, how filling pressures develop, how lactate develops. You don't want to see a rise of lactic acid in these patients. That's probably a sign of poor perfusion. So again, there is obviously, one would be happy to have rather clear-cut criteria and clear numbers, but it's something that sometimes that's something that you need to decide on rather subjective criteria on your own.
Okay. So Felix, we are on air for an hour about, so we kind of need to close down the session, but there are still a couple more questions by the participants, and maybe we can give an answer briefly. There's one question, and you mentioned that some of the advantages of doing the temporary RVADs rather than total artificial heart. One of the participants wants to know, is it at all effective or feasible to do a total artificial heart directly from a VA ECMO support?
That's a question that I can't really answer, because there is obviously centers who have great experience with total artificial hearts, for example, with the Syncardia system. We have used that as well in a small number of patients, and we used it from ECMO. But it's not something we do on a regular basis. I think total artificial hearts are something that you need in more severe situations, because in healthier patients you get away with your LVAD only. So I think that centers who do this in larger numbers, Bad Oeynhausen in Germany, for example, they do quite a lot. I think they do it successfully, and it works. We don't do it very often, so I can't really answer that one.
Okay. There's one question with respect to impeller venting. Do you see that there's a limit in impeller flow whenever you do venting?
Once you are on ECMO, the left ventricle doesn't fill normally. So as long as you are on ECMO, you will probably not be able to run the full flow that you would be able to pump without the ECMO circuit. If I have a patient who is on ECMO and who has an impeller in place, and I can pump 4 or 5 liters with the 5-0 pump, then I would really like to know why that is. I would like to rule out that the patient has aortic valve insufficiency or something like that, because that's not normal. As long as the patient is on ECMO and you use the impeller circuit as a vent, it depends. It's 1.5 liters, 2.5 liters, something in that size, I would say. It goes up once you have the ECMO out.
Okay. Now, Felix, all of those procedures are life-saving in these patients. Of course, we didn't really discuss a lot about complications, and I assume that would be primarily bleeding, any sort of clotting, including neurological problems and infection. In case you wanted to add something here, that you are absolutely welcome to do so. Otherwise, there would be one more question that I think is really important. One of our participants wants to know, how do you approach the problem that a patient that you consider probably neurologically fit to receive such a transition assist device procedure, but who would not be able to give consent at this stage? How do you approach this problem?
It would be fantastic to be able to talk to these patients, and it would be fantastic if they could consent to the implantation. So that's what we actually want to achieve, and what our intensive care specialists try to achieve, and what they work for. Okay, if that doesn't work, the very least we would need is, we want to see no obvious pathology on cranial computed tomography. And ask a neurologist to find signs of focal neurological deficit, and we don't want that as well. So given that we want to have the patient awake, but if we need to implant, if we need to proceed and it's not possible to wake them up at this point in time, we want to have a CAT scan that is okay, and we want to see an absence of focal neurological deficit. That means if you have them in your bed and you annoy them somehow, you want to see all 4 extremities moving, and that may well be enough in selected patients. It's not ideal to do it, but if that's the situation you are in, then that's what you need to deal with.
Have you ever experienced a patient that couldn't give consent, and after a successful full procedure and recovery, patient would complain about his situation?
Not that I remember. I mean,
I think that's an important message, right?
In every large VAD program, and we have seen that as well, you have a very, very small number of patients, and that's, I mean, we do perhaps 160 VADs, long-term VADs every year, so it's a substantial number, and we have done that for the last, I don't know, 25 years, so something accumulated. And I remember 2 or 3 cases that I have not seen myself, but that I have been told of, that committed suicide in the end. So I think that would be basically what you're asking for, but that's obviously a very small number, and it's that's obviously not a favorable outcome. But actually, it's at least something. It's giving the patient an option. It's sad, and it's not what we want, but these patients obviously had the option to make a decision. Yeah, and it's a decision that one needs to respect, and it's nothing that I would lose sleep over. The last thing what you said is about complications. Of course, we see them, and the same like everyone else sees. We see compartment syndrome, we see problems with perfusion, we see neurological problems. We see bleeding, we have to change ECMO circuits, we have to change ECMO cannula, and that's, at times, that's extremely annoying, because it can be quite a lot of work and quite a lot of time that you have to spend with a single patient, and you always have that risk that in the end they may not make it out of the hospital. So that's, you need to be prepared to do a lot of work, and in the end it doesn't work. However, there is patients that have horrible clinical courses and they get every problem that you can possibly imagine, and they still leave the hospital neurologically intact, and that's what I keep in mind whenever I have to do something at 4 a.m. in the morning that I actually don't want to do.
Okay, Felix, thank you so much. It's been a great presentation. It's been great to have an insight into the approach of your Berlin Center and how you do things. It's been a great discussion. Thank you once again. Thank you to all of our participants. I would like to remind all of you that we have an upcoming annual meeting in London, May 6 to 8, 2020. Please come and join. Felix will be there. A bunch of renowned experts from all over the world will be very available as part of our community, and there's lots to learn and lots to share there. So please consider coming. Please also stop by at our social media channels every now and then. We are on Facebook, on Twitter, and on Instagram. We have dedicated channels for the upcoming annual meeting. And with this, I would like to thank you, all of you, again, with our final reminders, as always. For one, you are only safe if your venous line is blueberry and your arterial line is cherryberry. And for the other, never ever forget breathing, other way it may cost you life. And with this, on behalf of EuroELSO, thank you very much. This is Peter Schellongowski from Vienna, Austria. Have a great holiday season. Take care of yourselves and join our next webinar. Thank you and goodbye.